Welcome to a video on potassium disorders. After watching this video on potassium disorders, you should be able to discuss potassium metabolism in terms of input, cellular shift and output, renal handling of potassium, be able to recognize the underlying etiologies of hypo and hyperkalemia, be able to determine renal versus extrarenal cause of the presenting potassium disorder, and be able to provide management plans for hypo and hyperkalemia. A little background on potassium. The total potassium content for an adult averages 3,000 to 4,000 millimoles, 98% of which is intracellular, and only 2% is in the extracellular space. The intracellular potassium concentration is approximately 140 millimoles per liter and 4 to 5 millimoles per liter in the extracellular space. Potassium plays a critical role in cell function and in neuromuscular transmission. It determines the excitability of all nerve and muscle cells, including the myocardium. Rapid changes in potassium concentration can be arrhythmogenic and life-threatening. How is potassium balance achieved? Looking at the big picture, there is input and output. Input includes dietary intake, supplements, or potassium-containing medications or intravenous fluids. Output includes bodily fluid loss, in particular gastrointestinal and urinary potassium loss. In addition to input and output, there is intra and extracellular shift of potassium. Imagine a friend here with his extracellular and intracellular space, intracellular potassium, and extracellular potassium. We can have intracellular potassium uptake for cell proliferation or release into the extracellular space and plasma in case of cell death or lysis. Potassium can be taken up intracellularly in exchange for sodium via sodium-potassium ATPase. This is an important transporter that is well regulated. Two major activators of sodium-potassium ATPase includes insulin and beta-2 adrenergic agonist. Overproduction of these activators can increase intracellular potassium uptake, thereby lowering plasma potassium concentration. An increase in plasma potassium concentration can also enhance intracellular uptake. A rise in extracellular osmolality can cause extracellular water shift, which can drag potassium along out of cells. This is known as the solvent drag effect. Changes in extracellular relative to intracellular pH can also induce an equivalent potassium exchange. The potassium exchange goes in the opposite direction as that of the proton-hydrogen. Protons travel towards the space with higher pH, that is, the space with less protons. For example, when the extracellular pH falls, there are more protons in the extracellular space. This would favor proton entry into cells. In exchange, potassium shifts into the extracellular space. On the other hand, when there is a rise in extracellular pH, protons would shift extracellularly. This would lead to an equivalent intracellular potassium shift. Finally, there is a potassium channel in muscle cells that is normally inhibited by adenosine triphosphate, or ATP. Depletion of ATP, as seen in exercise, causes this potassium channel to open and leads to the leakage of potassium into the extracellular space. This is thought to be a beneficial adaptive mechanism because the resulting increase in plasma potassium is vasodilatory, which increases blood flow to the exercising tissues. Additionally, this increased plasma potassium also leads to enhanced muscle contractility. We have discussed potassium input and cellular shifts. We will now discuss urinary output of potassium. This leads us to renal handling of potassium. We start with glomerular filtration of potassium. Approximately 90% of potassium follows the reabsorption of sodium and water in proximal tubules and gets reabsorbed passively. The rest flows through more distal segments. Approximately 5% gets reabsorbed at the thick ascending limb of loop of Henle, and the remaining recycles within tubular lumen. At the collecting duct, potassium secretion is regulated in principal cells. There is minimal potassium reabsorption via the hydrogen-potassium ATPase in alpha intercalated cells. Focusing on potassium secretion at collecting ducts. This is a multi-step process. First, sodium delivered to the distal lumen enters principal cells via the epithelial sodium channel ENaC, creating a negatively charged lumen. Second, sodium is reabsorbed in exchange for potassium via the basolateral sodium-potassium ATPase. Third, the accumulated intracellular potassium subsequently gets secreted into the lumen via the potassium channel down a favorable electrical and chemical gradient. The mineralocorticoid hormone aldosterone upregulates the entire process. Good urine flow ensures the maintenance of the favorable electrochemical gradient needed for continuing potassium removal. To summarize, effective and continuing potassium secretion at the collecting duct requires functioning ENaC, sodium-potassium ATPase, potassium channel, and the mineralocorticoid aldosterone, and a good urine flow. Of note, a high plasma potassium level can also contribute to activating these transport pathways to increase potassium secretion. Finally, there are apical potassium channels known as maxi-K or big K channels. They are present all along the nephrons, but are only known to play an important role in the distal convoluted tubules and cortical collecting ducts. Maxi-K channels are quiescent at basal state, but gets activated with increased luminal flow. This explains exaggerated potassium wasting in patients with high tubular flow with diuretics or Bartter syndrome. A side note about renal potassium secretion. For many years, there have been observations that in patients with concurrent low serum potassium and magnesium levels, repletion of magnesium is required to effectively replete potassium. One of the reasons behind this is as follows. This is a cartoon of the potassium channel ROMK with tubular lumen on top. Magnesium can narrow down the opening of the potassium channel ROMK and limit potassium secretion into the lumen. In a low magnesium state, potassium easily passes through ROMK into the lumen and gets excreted. Potassium supplementation in a patient with hypomagnesemia only leads to continuing potassium wasting through ROMK. This is thought to be a major mechanism whereby potassium supplement is ineffective in patients with concurrent hypomagnesemia. Bottom line, hypomagnesemia can be associated with hypokalemia. To effectively correct hypokalemia, magnesium supplementation must be given. Now that we've discussed potassium balance and normal renal handling of potassium, let's discuss what can go wrong with potassium balance. We start with hypokalemia, defined as having serum potassium level less than 3.5 millimoles per liter. Before discussing hypokalemia, we need to first briefly discuss pseudo-hypokalemia. Pseudo-hypokalemia refers to having a lower in vitro potassium measurement than its true in vivo level. It is important to recognize pseudo-hypokalemia because this does not need treatment. The most common reason for pseudo-hypokalemia is due to the presence of severe leukocytosis, a condition with very high number of active white blood cells, as seen in some forms of leukemia. What are the causes of hypokalemia? In terms of input, malnutrition with low dietary potassium intake, continuous intravenous fluid administration with no added potassium. In terms of intracellular shift, we can have rapid cell production, such as rapid blood cell production seen with B12 supplementation in patients with severe B12 deficiency, increased sodium-potassium ATPase activity with the administration of insulin, or beta-2 agonist, such as albuterol, a medication used to treat asthma. High plasma pH that may be seen in patients with acid-base disturbances or those receiving intravenous sodium bicarbonate infusion. In terms of output, we can have increased potassium loss via the gut from diarrhea or laxative abuse, or high renal potassium loss from the use of loop or thiazide diuretics, mineralocorticoid excess state, hypomagnesemia, or high urine flow. Finally, there is a very rare condition called hypokalemic periodic paralysis. This is an inherited condition where patients present with episodic paralysis and an associated fall in plasma potassium due to transient intracellular shifting of potassium. This condition can be triggered by strenuous exercise followed by rest, meals high in carbohydrates and sodium, or sudden changes in temperature or excitement. How do patients with hypokalemia present? Symptoms depend on the severity and acuity of the hypokalemia. Symptoms may range from muscle weakness, muscle cramps, and fatigue, to rhabdomyolysis and paralysis, constipation and paralytic ileus, and respiratory difficulty. There may also be ECG changes with hypokalemia. Characteristic findings include the appearance of increasingly prominent U waves, progressive T wave flattening, ST depression. In severe cases, arrhythmias and asystole can occur. How do we manage hypokalemia? Supplement potassium, orally or intravenously, depending on the severity. Concurrently, supplement magnesium if the serum magnesium level is low. Monitor for ECG changes and arrhythmias in severe hypokalemia. And of course, treat the underlying etiology or remove the inciting agent whenever applicable. Patients with recurring problems with hypokalemia may also be advised to increase intake of high potassium containing food. A few words of caution during the treatment of moderate to severe hypokalemia. Avoid the use of glucose-containing solution if possible. Glucose administration leads to endogenous insulin secretion by the pancreas. Insulin increases intracellular potassium uptake, thereby worsening the presenting hypokalemia. Avoid concomitant alkalinization because lowering plasma hydrogen level will stimulate intracellular potassium uptake, thereby worsening the presenting hypokalemia. Patients with moderate to severe hypokalemia may not be able to tolerate any further lowering of their plasma potassium. Life-threatening arrhythmias can occur. Moving on to hyperkalemia, defined as having serum potassium concentrations greater than 5 millimoles per liter. Before diving into true hyperkalemia, we need to first rule out pseudo-hyperkalemia. Pseudo-hyperkalemia refers to having an elevated in vitro potassium measurement that does not reflect true in vivo levels. It is important to recognize pseudo-hyperkalemia because this does not need treatment. The most common reason for pseudo-hyperkalemia is due to in vitro hemolysis due to mechanical trauma during venipuncture, resulting in increased cellular release of potassium. Another condition associated with pseudo-hyperkalemia is thrombocytosis, a condition where the number of platelets in the blood is increased. Pseudo-hyperkalemia may be seen with platelet count greater than 500,000 per microliter. The extra potassium released from the high number of platelets during the clotting process in the blood tube causes a high potassium level as measured in the lab. What can cause hyperkalemia? Starting with input, there can be very high dietary potassium intake, accidental oversupplementation of potassium, or ingestion of potassium-containing medications. Note that high dietary potassium intake alone typically does not cause hyperkalemia unless there is an output problem such as kidney failure or reduced urinary potassium excretion. In terms of extracellular potassium shift, there can be cell death or lysis that spills out intracellular potassium. Recall, unlike extracellular potassium concentrations, intracellular potassium concentration is very high, upwards of 140 millimoles per liter. Reduced sodium-potassium ATPase activity associated with insulin deficiency or the use of non-selective beta blockers with beta-2 antagonistic activity. Increased serum osmolality, as seen with severe hyperglycemia in patients with uncontrolled diabetes mellitus. Reduced plasma pH associated with acid-base disorders. Opening of ATP-sensitive potassium channel with ATP depletion, seen with repeated pumping of hand during blood draw. In terms of output, there can be reduced intestinal excretion associated with severe constipation, or reduced urinary potassium secretion due to the use of potassium-sparing diuretics, renin-angiotensin-aldosterone inhibitors, or urinary retention or obstruction. Finally, hyperkalemic periodic paralysis is a very rare inherited condition where patients present with episodic paralysis and associated rise in plasma potassium due to transient extracellular shifting. This condition may be triggered by rest after exercise, change in daily activity, especially in cool temperature. What can go wrong with potassium secretion at the collecting duct to cause hyperkalemia? There can be inhibition of ENaC with the use of medications such as amiloride or trimethoprim. There is no known acquired problem with sodium-potassium ATPase or ROMK that could cause isolated hyperkalemia. There can be reduced mineralocorticoid activity. This can be seen with adrenal insufficiency with reduced aldosterone synthesis, or the use of inhibitors of the renin-angiotensin-aldosterone system. Finally, urinary obstruction or retention can interfere with optimal potassium secretion. Clinically, patients with hyperkalemia can present with muscle weakness and, in severe cases, paralysis, paresthesia, depressed deep tendon reflexes, muscle cramps, nausea, vomiting, and diarrhea, and in severe cases, there can be bradycardia, arrhythmias, and asystole. What do we expect to see on ECG as serum potassium levels rise above normal range? Starting from a normal morphology. As serum potassium increases, typically above 5 or 6 millimoles per liter, peaked T waves may be seen, followed by prolonged PR intervals and loss of P waves, widened QRS intervals, sine waves, followed by ventricular fibrillation. How do we manage hyperkalemia? The key in the management of moderate to severe hyperkalemia is to monitor for ECG changes and arrhythmias. Stabilize cardiac irritability with intravenous calcium gluconate if there is peaked T waves or worse ECG changes. Urgent steps to take in patients with ECG changes include rapid induction of intracellular potassium shift with the administration of intravenous insulin and glucose. The addition of glucose is to prevent hypoglycemia with the use of insulin. Patients with concurrent low plasma pH can also be alkalinized with intravenous infusion of sodium bicarbonate. If patients can take oral medications, we can add medications to increase intestinal excretion of potassium. These include the use of cation exchangers to exchange potassium for another cation such as calcium or sodium in the gut. In patients who are volume overloaded, Diuretics may be used to simultaneously diurese the volume and excrete the potassium. In patients with kidney failure, emergent hemodialysis may be done. Finally, we will also need to treat the underlying cause or remove the source of hyperkalemia whenever applicable. This table is for your reference only. It provides basic treatment options for hyperkalemia. For patients with recurrent hyperkalemia, educate and advise low dietary potassium intake. How do we evaluate a patient with either hypo or hyperkalemia? In terms of history, check for problems with input and output. Medications that can increase or decrease potassium levels. Review blood chemistry, including magnesium and bicarbonate or pH, and glucose level. Check for evidence of rapid cell death or proliferation. In addition to obtaining a full medical history and reviewing laboratory findings, we can obtain any of the different urine indices to determine if the presenting potassium disorder, whether it be hypo or hyperkalemia, is the kidney's fault, that is renal, or something else, that is extrarenal in etiology. For example, if a patient has hypokalemia and there is a high level of potassium in the urine, we can assume that the presenting hypokalemia is due to renal potassium wasting, which means that any of these problems could be contributory. On the other hand, if the patient's urine potassium level is low, it means the source of the hypokalemia is not from the kidneys, or we can say that the source of hypokalemia is extrarenal, which means any one of these problems could be contributory. If a patient has hyperkalemia and the urine potassium is low, it means that the kidneys cannot excrete potassium well. This means the presenting hyperkalemia is renal in etiology. Any one of the following could be contributory. If the urine potassium level is high, it means that the kidneys are actually helping to get rid of the high potassium load. This means the presenting hyperkalemia is due to causes other than problems within the kidneys or extrarenal. Any one of the following could be contributory. With a complete medical history and analysis of urine studies, we can narrow down the differential diagnosis and better determine the cause for the presenting potassium disorder. In summary, we have discussed potassium metabolism in terms of input, cellular shift, and output. Factors that determine cellular shift include plasma potassium level, cell proliferation or death, sodium-potassium ATPase activity, plasma osmolality, plasma pH, and ATP-sensitive potassium channel. Factors that affect renal handling of potassium include glomerular filtration, collecting duct function, mineralocorticoid state, plasma magnesium level, and urine flow. Determination of renal versus extrarenal cause of potassium disorders based on urinary potassium content. Differential diagnosis of potassium disorders based on input, cellular shift, and output. And finally, we've also discussed clinical manifestations, ECG changes, and management of potassium disorders. This time, you should be able to discuss potassium metabolism in terms of input, cellular shift and output, renal handling of potassium, be able to recognize the underlying etiologies of hypo and hyperkalemia, be able to determine renal versus extrarenal cause of the presenting potassium disorder, and be able to provide management plans for hypo and hyperkalemia. The end.